Hey everyone, it's Dr. Hodges, and today is day 3 of Obesity Cares Week. And what we're going to discuss today is medicine as part of your weight loss program. You know, by trade, I am a board certified surgeon specializing in bariatric surgery, but with my patients that come to see me, I also offer non-surgical options. And in my comprehensive program, I use medication, diet, behavioral health, and nutritional counseling, all to help to give people a more comprehensive program so they can have the best possible results. You know, the medicine has really come to the forefront of weight loss, especially with the surge in GLP-1, so all the injectables that are on the market. And I mean, if you've been on any Instagram or TikTok or YouTube, at some point I know that you've seen a video about Ozempic and Ozempic face and all the injectables. So what I really want to try to do today is talk about first the medicines that are available, because there's more than just the injectables, but then number 2, how they really need to be used in a program so that patients can have the best long-term results. So let's just jump right on in. So in my practice, there are 3 main medications that I might use to help people in their weight loss journey. And I think that there's a couple of things to remember with any of the medications, regardless of what they are. Number 1, the medications are not magic. And I say that also about surgery too. So there's nothing magical about the medicines. Taking a higher dose is not going to make you lose more weight. All the medicines do is suppress your appetite so you can remain in a calorie deficit. And the research is showing that you will lose weight and you'll lose a greater amount of weight if you focus on maintaining a good calorie deficit as opposed to just focusing on your macronutrients, which would be protein, fat, and carbs. So what does that really mean? That means that your BMR, which is your basal metabolic rate, that's up here. You need to keep your calories below that. So that difference is the deficit, kind of like what we have in DC right now, great big deficit in our budget. So that means like the amount below than what we really have. So the larger your deficit, the more your body is going to use its own fat stores and unfortunately some muscle mass too, to tap into for energy, as opposed to deriving energy directly from the food that you eat. So they have found that it's more important to maintain a deficit as opposed to just looking at how much fat, carb, or protein that you're taking in. And usually what I see is if somebody's on a special diet where they're focusing on only 1 or 2 of those macronutrients, or they're trying to exclude some of those, such as like in a keto diet, you're keeping your carbohydrate levels very, very low. A lot of times by default, because you're being so mindful about the foods that you're eating, that in and of itself kind of puts you into a calorie deficit. So I think one key take home for this is that it doesn't matter what medicine that you take. If you are not maintaining a calorie deficit, you will not lose weight. And that's also why some people can take the medicine and they lose more weight compared to somebody else. Well, if somebody has a BMR, meaning a basal metabolic rate, that's much higher than yours, then at the same caloric intake, you can lose or gain more weight than that person. So for instance, for me, my metabolic rate is right around 1100, well, it's like 1087. That means for me to lose 1 pound, I need to be in a 500 calorie deficit every day. So that would mean I would need to net 600 calories, not a lot. That's why I usually have to also do some exercise, because I would never tell anybody to eat that far below 1,000 calories. As opposed to somebody that maybe their metabolic rate is 2,100 calories. Well, that patient, they could take in 1,600 calories every day and they would lose 1 pound a week. If I take in 1,600 calories, I will gain 1 pound. So can you kind of see that where your BMR lies, that's kind of where that's what your stepping off point needs to be. And down in the bio, I will have a little link to a calculator so that you can determine what your basal metabolic rate is, because that is going to be key for any weight loss program, particularly if it's non-surgical, because right now you're really having to rely on exercise and diet to get you to your weight loss goal. So what happens when you go into a deficit? Your appetite is going to go up. That is how your body was designed. It is way easier to derive calories from the food that you eat than from tapping into your fat stores and also from your muscle, because those actually take energy. So it takes energy to break down the energy. And so it is a very natural thing for your appetite to increase whenever you go on a diet, or if you're exercising a lot, because if you're exercising a lot, you're burning more calories, your body needs more fuel. So all the medicines do is suppress your appetite so that you can more easily maintain a calorie deficit. And what I also like patients to know is, for most of these medications, well, really, I kind of think all of them, the primary endpoint of these medications was not really for it to suppress your appetite. The purpose was usually for something else, and they found that the appetite suppression was a side effect. And so, like most side effects, over time, your body will develop tolerance, which is why over time, you usually have to increase the dose. Or if, like in the case of phentermine, after you've been on it for a while, you no longer have any appetite suppression. And that's just because your body has become tolerant to the side effect of that medication. And I think that that's key. So it's not that you're broken. It's not that the medicine just is broken. It's just that over time, your body has gotten smarter. So let's kind of dive right in. With the different medications, there's Contrave, and that is made up of Wellbutrin and naltrexone. There is Qsymia, and that is made up of low-dose phentermine and Topamax. And then there are the GLP-1 injectables. So let's talk about the medicines that you take on a day-to-day basis. So this is going to be once or twice a day dosing orally. So the first is going to be Contrave. It is Wellbutrin naltrexone. It is not a straightforward appetite suppression. What it does is it kind of works on that reward system in your brain. So it kind of kills your desire for you to eat or to snack. One of the components, naltrexone, is actually something that we give people that might be an addict, and that has been really good at shutting off that reward cycle in your brain, so people don't get the same kind of like high or gnawing or desire to drink. And so we found that you can kind of across the board use that. That's even with Wellbutrin. It kind of helps with that reward cycle. That's why if somebody's trying to quit smoking, their doctor may put them on Wellbutrin. I think it's called something else, but all it is Wellbutrin. It's bupropion. And so what they found is that if they mix bupropion with naltrexone, and now they just called it Contrave, it can really do a good job of helping people to lose weight by suppressing their appetite and kind of like killing that desire. I've taken all of these medicines, and what I particularly found on Contrave is that whenever I would sit down to eat, like it suppressed my appetite, but what I really found is that when I would sit down to eat, I only ate a little bit because I like lost the desire to eat, and I also lost the desire to snack. So that was very helpful for me in maintaining a calorie deficit. The next medicine on the market is really the OG. It's phentermine, and you take that on a daily basis. There was a drug company that came out, and they found that if they made a combo drug of phentermine with Topamax, and Topamax is actually medicine that is used for seizures and for migraines, they would work synergistically together to really suppress your appetite. And that works really well. The only problem with that medication is that as you increase the dose, particularly of the Topamax, and if you're taking Qsymia, as you also are increasing the phentermine, over time, you just become tolerant to the medicine, and the medicine just doesn't do a very good job of suppressing your appetite. Unfortunately, with phentermine, is not something that I would recommend patients continue to take indefinitely. There are some folks that will only give it to people for 3 months, although I will tell you for Qsymia, I think all the studies looked at patients on the medication at 24 months. So I typically don't have a problem having patients on medication for that long. Finally, there are the newest drugs that are on the market today, and those are the injectables. The first injectable that was out was, it was created for diabetes, and it was made by a company, Novo Nordisk, and they created Victoza. Then Victoza, that was once a day dosing, and then they made that as an extended release, and that was named Ozempic. And they found as one of the side effects of Ozempic is that there was some appetite suppression. Patients would lose weight. Patients might lose 20 to 30 pounds. And so they just remarketed Ozempic as Wegovy. There is a competitor to Ozempic. The competitor to Ozempic is Mounjaro. The indication for Mounjaro is diabetes. It also is once a week dosing. They too went to the FDA. They just rebranded Mounjaro as Zepbound. So the generic name for Ozempic and Wegovy is semaglutide. The generic name for Zepbound and Mounjaro is tirzepatide. And all of these are once a week dosing. Now, well, how do these medications work? So they interact with a little receptor that is in your gut. Semaglutide affects one receptor, tirzepatide affects two. And whenever you eat, food goes down your esophagus, into your stomach, into your small bowel. And the primary mechanism of action is for it to kick the pancreas into high gear. So when your glucose gets up a little bit after you've eaten, if your glucose has gotten up too high, it will cause the pancreas to secrete more insulin so that you can then have better control of your glucose. They found that one of the other things that receptor will do when it's activated, because typically it's in the presence of food, it will send a signal to the brain to tell you that you are full. So the feeling of satiety, so the feeling of fullness, is just a side effect of these injectables. And that is why over time you need to slowly increase the dose of your injectables. So how do you know when you need to increase your dose? I know the manufacturer wants you to increase the dose every month. I typically in my practice don't do that. I will have patients on the lowest dose, and this is for all of the weight loss medicines. Take the lowest dose that is the most effective, because I know over time you're going to become tolerant to that medication. Okay, so how do you know whenever you're taking an injectable that you need a new dose? Let's say you take your medicine on a Sunday. If you're finding by Friday or Saturday that you're getting the munchies, that usually means you need to call your provider, get the next highest dose. Okay, so those are the injectables in a nutshell. Again, there is nothing magical about these medicines. I was just watching TV this past weekend, and there was an advertisement for Mounjaro, and it specifically said patients on average will lose about 25-30 pounds, which, you know, if somebody is on Qsymia, which is Phenerine and Topamax, or if somebody's on Contrave, they're going to lose roughly that, maybe a little bit less. So, you know, I have seen in my practice, and also nationally, you know, there's been this huge push for appetite suppressants, and for especially for these injectables. I mean, they've gone on back order, they've been in short supply, but the reality is patients are usually losing anywhere from 20 to 30 pounds. Now, can patients lose more? Yep, but I will tell you, a couple of years ago, I lost 45 pounds, and the only thing that I did is I took Contrave and I walked every day. So you do not have to have an injectable to get to your weight loss goals. I think that's the key point. I think the benefit of an injectable over a once a day dosing is the fact that it's extended release, and so your appetite suppression is just much more longer lasting. A lot of times if somebody's taking an oral medication, I might tell them to take it maybe a little bit later on in the day. So maybe not first thing in the morning, maybe mid-morning, or maybe even at lunch. That way the efficacy, so that bell curve of that active time for that medication to actively suppress, it's now kind of shifted towards more mid to late day, because usually that's when patients are having or needing the most appetite suppression. So I think some of the key take-homes with this is, number one, you really need to have a comprehensive program. If your doctor or whomever or your med spa is just giving you some medication, I will tell you, with all of these medications, it doesn't have to be an injectable, you're going to lose about 5-10 pounds. You're going to do it. If you want to lose significantly more weight, though, you really need to have a more comprehensive program. And I think the other thing to know is that you need to look at your weight for what it is. It is a disease process. And so it is something that is going to be ongoing. If you would struggle with your weight all your life, you may find that just trying to do medication, along with diet and exercise, that might not be enough to get you to your weight loss goals. I have certainly found that if you have more than 30 to 40 pounds to lose, you might as well have 140 pounds. And the reason why is once your BMI gets, you transition from being in a normal BMI to overweight to now obese, and obese is any BMI 30 and above. All those processes that govern digestion, so your feelings of hunger, your feelings of satiety, your how your body utilizes glucose and fatty acids, how all these things are metabolized and stored, all of those things become very, very skewed, very deranged once you become overweight. Those digestive pathways do not work like they should. And because now they no longer work like they should, that's where we get into the disease of obesity. And that's why it becomes increasingly difficult to lose weight the more weight that you gained. So just like cardiovascular disease, you might be predisposed to having heart disease. That is the exact same with obesity. You can have patients that have horrible diabetes, and they just might be mildly overweight. Whereas I might have somebody that comes to see me and they're 300 or 400 pounds. They don't have high blood pressure, they don't have diabetes, and they don't have high cholesterol. They are just very overweight. They're obese. But we have to get that weight off, because obesity, so having a BMI over 30, has been shown to be an independent risk factor for 13 different cancers. It is an independent risk factor for heart disease, for stroke, for diabetes, for PCOS. So we really have to work to get under control. You know, I'm a surgeon by trade. I'm a board certified surgeon, and I specialize in bariatric surgery. And it always hurts my heart just a little when I have a patient that comes to see me and they're like, "Doc, I just want to start with some medicine." And they're coming to see me and their BMI is 40 or 45. And maybe they need their hip replaced or they need their knee replaced. And what's unfortunate is I know that medicine can help a little bit, but they're not going to have lasting results. I mean, the research shows that the recidivism rate, meaning your risk for weight regain, is over 95%. And that's with across the board, looking at all the diets and all the different programs that are on the market today. So a lot of people can lose the weight, but what we really need is we need that weight to stay off. And all the research has borne out that surgery, hands down, is what can help you, give you the most long-lasting results. So the success rate for weight loss surgery is closer to 85 to 90%, which is better than 2% with medical weight loss. With that being said, you need to look at your weight for what it is. It is a chronic disease. If there's anything that you take home this whole week, it's going to be weight, and obesity is a chronic disease. It needs to be treated as such. I really encourage you, whether you're looking at a medical weight loss, which is non-surgical, or if you're looking at surgical, or if you just don't know, go see a reputable provider. I will tell you, I do telemedicine in my practice. So even if I have patients that are out of state, I'm able to see you. I'm going to have some links below to my website. You already found me on YouTube. I have a Linktree site so that you can get some really good information on weight loss, on medical weight loss, and on surgical weight loss. So I hope that this kind of helped to clear up some of the myths for medications. It is a wonderful adjunct to any weight loss program, but I want you to know it is not the end all of end alls. Actually, nothing is. It's really going to be a good comprehensive approach to your weight loss that is going to get you to your long-term goals and help you maintain those, most importantly.